Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 451 of our pharmacotherapy series, which majors in lung cancer. The next case reads, LML, an 85-year-old woman, presented with a mild cough, productive with non-bloody sputum, shortness of breath, and fever. She was initially seen by primary care physicians who treated her with antibiotics for possible pneumonia. However, the radiogram of the chest showed a persisting infiltrate in the left upper lung. This was later confirmed on ACT scan with the presence of a 6 by 3 by 3.6 cm mass in the left upper lobe. Mediastinal adenopathy and multiple pulmonary nodules were seen in the right upper lobe with associated scarring, the largest of them measuring 14 by 9 mm in the right upper lobe anteriorly. Transbronchial biopsy led to a diagnosis of adenocarcinoma. Because of the spread of disease to the contralateral lung, disease was staged as IV. Pertinent patient history included hypertension and hyperlipidemia. The patient also had a hemangioma of the brain resected in 1950 and a history of cervical cancer treated with an abdominal hysterectomy in 1952. She has never smoked. Upon evaluation, she was found to have a hemoglobin that was slightly low at 11.3 grams per deciliter, with a white blood cell count of 5,200 cells per microliter and a platelet count of 245,000 per microliter. The electrolytes showed normal sodium of 143 milliequivalents per liter, normal potassium of 4.4 milliequivalents per liter, and creatinine of 1.08 mg per deciliter, with estimated creatinine clearance of 48 ml per minute. Her performance status was 0 to 1. What are the treatment options for patients such as LML with advanced, that is, stages 3B and 4, disease? We will begin with surgery. In general, tumors in patients with stages 3B and 4 disease are inoperable. These tumors often invade the carina, great vessels, vertebral bodies, more distant lymph nodes, metastases, and are frequently associated with malignant pleural effusions. Hence, combined modality treatments such as cytotoxic chemotherapy and radiation are the preferred treatments for patients with advanced stage disease. Surgery to remove solitary metastatic sites may also be considered in selected patients, especially in patients with a solitary brain metastasis. Next we will focus on radiation. Radiotherapy is the primary local treatment, i.e., definitive radiotherapy, for inoperable non-metastatic non-small cell lung cancer, and is also used as a palliative modality for patients with incurable disease with symptoms such as pain or shortness of breath. For tumors classified as stage 3, radiotherapy is often given concurrently with chemotherapy, as this has been shown to be superior to both radiation alone and also sequential radiation followed by chemotherapy. The radiation dose, in combination with chemotherapy, usually ranges between 60 and 65 Gray, abbreviated as GY, given in 2 Gray's fractions. The recommended chemotherapy regimen for stage 3 disease with radiation is either cisplatin and etoposide or carboplatin and paclitaxel. If the patient has adenocarcinoma, then pemetrexed may be substituted for the etoposide or paclitaxel. Metastases may also be treated locally with radiotherapy. For example, brain metastases, spinal cord compression, and impending fractures of weight-bearing bones can be treated with radiation or surgery before systemic therapy commences. In contrast to patients with stage 3 disease, those with stage 4 disease usually receive local treatment with radiotherapy, either before or after chemotherapy, because therapy given concurrently is often not well tolerated by patients with this stage of disease. We will now shift gears to chemotherapy. Patients with advanced disease and good performance status usually benefit from chemotherapy. Similar to early-stage disease, these tumors often respond to treatment with platinum-based doublet cytotoxic combination therapy, which refers to treatment with either cisplatin or carboplatin plus a second cytotoxic agent. Non-small cell lung cancer was treated as a single disease, despite recognition of its histologic and molecular heterogeneity, but recent clinical trials demonstrate that histology is an important factor for individualizing treatment based on either safety or efficacy outcomes. Hence, once the biopsy is obtained, it is crucial to differentiate the histologic subtype, i.e., squamous versus non-squamous. The role of histology in the management of advanced non-small cell lung cancer is reviewed more extensively elsewhere. In developed countries, an increasing incidence of adenocarcinoma and a decline in squamous cell carcinomas have been observed in recent years. This appears to be correlated to declines in smoking rates. Many agents are effective against all histologic types such as cisplatin, carboplatin, gemcitabine, and paclitaxel. However, other agents such as bevacizumab and pemetrexed are only indicated for use in patients who have the non-squamous histology. Squamous cell histology is associated with increased risk for severe pulmonary hemorrhage compared with adenocarcinoma. For pemetrexed, significant association between improved efficacy and the non-squamous subtype has been reported. Characterization of advanced non-small cell lung cancer tumors at the molecular level has also become part of clinical practice. It is recommended that tumor tissues from patients with non-squamous histology tumors should be analyzed for the presence of epidermal growth factor receptor and ALK mutation status. Tumors that are positive for epidermal growth factor receptor somatic mutations are often more responsive to erlotinib therapy and have become the standard frontline treatment over cytotoxic chemotherapy. This analysis is limited to patients with stages 3B or 4 disease, because erlotinib has not been proven to be beneficial in patients with earlier stage disease and epidermal growth factor receptor mutations. For the advanced disease setting, therefore, treatment decisions are becoming more individualized on the basis of tumor histology and somatic mutations. As more targeted therapies, designed to inhibit other targets, are approved, it is likely that their use will be based upon at least some of these same principles. Patients who respond to treatment or achieve stable disease after 4 to 6 cycles may be given maintenance therapy. The intention of such additional treatment would be to prolong the response and survival made possible by first-line treatment, while minimizing the chances for toxicity associated with platinum-based doublet regimens. Maintenance therapy differs from second-line therapy in that second-line treatment is only used when the patient has progressed during or after first-line treatment or is unable to tolerate it. Maintenance may be given as continuation maintenance, which refers to the use of one of the agents given in first line. Often, biologic agents that were given as part of the first-line regimen, e.g., bevacizumab or cetuximab, are continued due to their better tolerability relative to the cytotoxic agents. For adenocarcinoma, pemetrexed should be given as continuation maintenance treatment due to an improved overall survival compared to placebo. Alternatively, the agent may be different from those used in first-line treatment and is referred to as switch maintenance. Pemetrexed, erlotinib, and docetaxel are three agents for which there is supportive clinical trial data in the switch maintenance setting. The first two agents are associated with an improvement in overall survival and have an indication for use in this setting. Next we will briefly look at palliation. Patients with metastatic non-small cell lung cancer receive benefit from palliative care early after diagnosis, rather than waiting until end-of-life care. This palliative care includes helping the patient cope with the psychosocial aspects of their disease through methods such as counseling, e.g., expectation of treatment outcomes and affordability of treatment. In a study of patients with metastatic disease, subjects were randomly assigned to receive either early palliative care integrated with standard oncologic care versus standard oncologic care alone. Patients assigned to early palliative care experienced a better quality of life and survival, that is 11.6 versus 8.9 months, than patients assigned to standard care alone. They also experienced fewer depressive symptoms, that is 16% versus 38%. The results show that palliative care is appropriate and potentially beneficial when it is introduced at the time of diagnosis at the same time as other beneficial therapies. In conclusion, LML would not likely receive benefit from surgical removal of the primary tumor or metastatic site. Instead, chemotherapy is the treatment of choice with a pemetrexed-based regimen along with maintenance pemetrexed for controlling disease that has already spread. Consideration for palliative care would also be beneficial. The tumor tissue was sent out for analysis of the presence of an epidermal growth factor receptor mutation. So my next question to you is, what characteristics in LML would prompt a decision to send a tumor specimen for analysis of an epidermal growth factor receptor mutation? The importance of this analysis is underscored by the fact that patients with epidermal growth factor receptor mutation positive advanced stage tumors respond better to treatment with erlotinib than they do with conventional chemotherapy. Furthermore, erlotinib is better tolerated than doublet platinum-based therapies. Therefore, patients with epidermal growth factor receptor mutation positive tumors would be expected to experience better outcomes related to both tumor response and tolerability. Soon after erlotinib was approved by the U.S. Food and Drug Administration, FDA, investigators noticed that patients who were women, Asian, and non-smokers tended to respond to erlotinib therapy more frequently than other populations. However, it was subsequently realized that presence of mutations in epidermal growth factor receptor was a better predictor of response to erlotinib therapy than demographic factors and smoking status. The prevalence of epidermal growth factor receptor mutations is between 10% and 15% for the overall population, but is 35% in white non-smokers, and 65% for Asian non-smokers. Hence, the probability that LML, a non-smoking white woman, has a tumor with this somatic mutation is higher than for other categories of patients such as smokers or men. Further, the observed incidence of these mutations is less than 3% for patients with squamous cell histology. Therefore, it is not recommended to test patients with this histology. LML was diagnosed with adenocarcinoma, which is a non-squamous subtype, and mutation testing is thus warranted on that basis alone. The question arises that patients who fall into the category with multiple clinical predictors of response could be started empirically on erlotinib therapy without the need to test for epidermal growth factor receptor mutations. In LML's case, she would be classified as having 3 of these clinical predictors: female, non-smoker, and adenocarcinoma. However, studies with populations of patients from developed countries with non-small cell lung cancer showed that those who had 3 or more of these characteristics experienced a 49% response rate, whereas those with sensitizing epidermal growth factor receptor mutations experienced a much higher 67% response rate. This indicates that epidermal growth factor receptor mutation is a better predictor of response to erlotinib therapy than presence of multiple clinical predictors. Additionally, a second epidermal growth factor receptor inhibitor, afatinib, is now available for patients with activating mutations of epidermal growth factor receptor. Afatinib is an irreversible inhibitor of epidermal growth factor receptor, whereas erlotinib is reversible. That has been shown to be superior to treatment with conventional chemotherapy as well as a second-line option for patients who have progressed on frontline erlotinib therapy. Application of this epidermal growth factor receptor testing is useful for small molecule tyrosine kinase inhibitors, e.g., erlotinib, or afatinib, but not for antibody molecules, e.g., cetuximab, that also block epidermal growth factor receptor. The antibody molecules function to block the receptor external to the cell's surface, and they also stimulate immune responses, e.g., antibody-dependent cell-mediated cytotoxicity, complement, against the tumor. It is likely that even without presence of the mutation or mutations, the antibody molecule still binds and can function through several mechanisms to promote an anti-tumor effect. Small molecule inhibitors, however, also bind the receptor internal to the cell's surface and can inhibit the active ATP binding region, which is constitutively activated in tumors with epidermal growth factor receptor mutations. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 452.